The future of poverty is urban. All future growth is urban. It's the fastest growing population by far in the world, and the fastest growing population within the urban sector are the urban poor. It's critical that we understand how we can serve them in all health areas, including family planning.
The goal of the Urban Reproductive Health Initiative is to increase significantly modern family planning use in the target cities in the 4 countries, with a particular emphasis on the urban poor.
It's a proof of concept of supply side, demand side, and advocacy interventions with a rigorous evaluation component to drive contraceptive uptake across 4 different country programs: Senegal, Nigeria, Kenya, and Uttar Pradesh in India.
The Measurement, Learning, and Evaluation Project's goal was to evaluate the programs in all 4 countries and to provide lessons for the global community on what works in terms of family planning for these urban settings.
These are multifaceted programs with lots of different supply and demand side interventions. The challenge that they posed to us is that they wanted to be able to measure the impact of these programs component by component.
This particular approach to evaluation and evidence building was intentionally designed to continuously improve the program.
The data also enabled them to speak in a way that was meaningful to government partners, to other donors, to academics.
Le Sénégal est un pays avec 95% de musulmans. Le Sénégalais a besoin de savoir ce que l'islam pense de la planification familiale.
Après avoir réalisé l'enquête à mi-parcours, nous avions fait l'analyse d'impact, donc avec des modèles multivariés. Nous avons pu démontrer que les religieux ont impacté surtout sur l'approbation des hommes. Les hommes qui ont eu à entendre un leader religieux parler en faveur de la planification familiale, ces hommes-là étaient plus favorables à approuver la planification familiale que ceux qui n'ont pas entendu ce leader religieux.
Si le projet a pu être flexible, c'est parce qu'on a eu à chaque fois des données qui nous permettent d'avoir des évidences pour pouvoir quand même être flexible et réorienter nos interventions. En tout cas, ça nous a valu en tout cas aujourd'hui de passer de 19 approches à 6 approches qui feraient le même impact. Nous sommes beaucoup servis des données du midterm de MLE pour designer ce package. Et dans ce package figure la collaboration avec les religieux.
Kenya is a country with a population of about 43 million, but the growth rate is very high. Every year, we are increasing by about 1.1 million. It was much easier to be able to change strategy because you find that given the data set that we were able to get, the innovations that we came up with were to address those particular gaps in service delivery.
This is the first experience of a longitudinal study of family planning as to the issues, as to providers, as to clients and consumers.
The lessons that we've learned are shaping the work we're doing now for the follow-on to NURI. Those lessons are going to be expanded and learned and shared and implemented beyond the states that we're in.
The advantage of this data is that it's giving us credibility. Because when people ask us, how did you do it? We say, this is what we did, and this is what the data says.
The end result is the proof of concept basically worked. We showed that the family planning programs worked. We also showed that there were certain interventions that were more cost-effective than other interventions. So that's good news when they start trying to replicate this in other countries.